Veerinagi Rajesh, medical consultant from Arvind Eye Hospital, Madurai. So, in this webinar, in continuation with the previous two topics, the first one about the topical medication, and the second one where the sister spoke about the maintenance of the drug. Here we are going to speak about how are we going to administer a drug. So, the basic knowledge we should have when we administer a drug is 5 R's: the right patient, the right drug, the right dose, the right route of administration, and the right time. So I think everybody will understand what is giving a right drug to the right patient. But what does right time and frequency of administration means? For every drug, there is something called T-half, the half-life of a drug. So depending upon that, the frequency of the drug will be there. For example, if you have an anti-glaucoma medication, for example, Timolol, so you will know it's usually given as BD dosage. That is because the T-half is that way. Similarly, prostaglandin, which is another anti-glaucoma medication, there usually it is given once in the night. So depending upon the T-half, the time and frequency of the drug varies. Coming to the next are the right dose. So similarly, as I said earlier, topical medications, it is little different. But when we come to oral medications, the dose depends upon the age and the weight of the patient. For example, if I have a steroid, usually it is given at the dosage of 1 milligram per kg body weight. So the dose is going to be different for different age groups and different weight of the patient. Coming to the right route. For an example, if I say a case of conjunctivitis, if I give a topical antibiotic, it will work better than giving an oral antibiotic in the patient. So right dose, right time, and right route is very important when we are administrating medications in the patients. Last but not the least, now the recent trend is right documentation. So unless you have done a documentation, whatever you have done as a checklist is not included as you have done it. So once we have administered the drug based on all these 5 R's, there will be a reaction. So the reaction may be a desired effect, what we want in the patient, or an undesired effect. So the undesired effect, which we call as adverse drug reaction, may be something as mild as headache, nausea, vomiting, or rashes or allergy at the site of injection, or something very severe like a teratogenic effect. Teratogenic effect is something what a newborn child gets because we have given a drug to the pregnant mother. So the adverse drug reaction can be simple or very severe. So adverse drug reaction is defined as unwanted, uncomfortable, or dangerous effect that drugs may have. So it may be mild or it may be severe, and in few cases it may be even life-threatening. So we will look at few ophthalmic examples for this. For example, post-fundus fluorescein angiography. So few patients may develop adverse drug reaction to fluorescein dye. Similarly, few patients may develop allergy to either a topical or a subtenon or a block for a patient before cataract surgery or other ocular surgeries. So once we have an adverse drug reaction and once we have managed it, you have to identify and document the event and the type of management you have done for the patient. We have to report the incident. We have to analyze how the incident happened, and we have to write an analysis of how the action is taken. For example, this is the adverse reaction reporting form available in Arvind Eye Care system. So here they will describe whether it was a mild reaction or a moderate reaction or a severe reaction and the type of treatment given for the patient. So the definition may be different for different hospitals, but you have to have your own mild, moderate, and severe. And also you have to list out what are the medications given in the patient, because not every time it will be a single drug. In fluorescein, maybe it may be a single drug, but when it is a pre-cataract surgery, it may be multiple drugs. So only when you note down what are the multiple drugs, when similar reactions happen very frequently, you can point out and say which drug could have been the cause for the adverse drug reaction. So once adverse drug reaction has happened, you have to do a root cause analysis. You have to report it to the through an incident form, and all the staff who are related to the event should be aware of such a event has happened. And after root cause analysis, you have to do a proper corrective action and preventive action. So we saw adverse drug reaction which we may not expect in a patient, but in few cases, few drugs are contraindicated. That is, even before you give a drug, you will know that those patients may develop some reaction to the particular drug. For example, in common OPD procedure, as a routine in an ophthalmic setup, we dilate, like we use mydriatics in most of these patients to dilate the pupil. But if you have noted properly, few patients may develop allergy to these common dilating drops. So if you have already monitored and documented that this patient is allergic to this particular dilating drop, you will not use the same drop again. So for that patient, the drop is contraindicated, because when a patient comes in with a problem, we should not send them back with another new problem. Similarly, few patients may be allergic to few topical antibiotics. In the same way, like in OPD, in operation theater, before a cataract surgery or before any other ocular surgery, when we are using topical anesthesia or including a Hyalase, few patients may be allergic, which we would have noticed in the previous other eye surgery. So in cases where we have documented this, we will know that these drugs are contraindicated to use again. Then we have intracameral antibiotics. These are antibiotics which we injected into the anterior chamber at the end of the surgery to prevent infection post-operatively. So again, few patients may be allergic to the moxifloxacin, which is commonly used. So in those cases, again, we have to plan what we are going to do for these patients intraoperatively. So we spoke about topical injections and intracameral injections. Next comes contraindication for systemic medications. For this, like when I say systemic medications, we are speaking about oral and parenteral. Parenteral is IM, IV, and other medications. So for this, you should know what is pharmacokinetics and pharmacodynamics. These are nothing but pharmacokinetics and dynamics means what the drug does to your system, what your body does to the drug. Okay, so what happens, how the drug is getting metabolized in the system, or the drug, what it can cause to your system. For example, FFA, fluorescein, and IV mannitol both are excreted through your renal system, through your kidney. So before giving this drug, you have to look at your renal status. So patient's renal status is evaluated using a blood urea and serum creatinine, and only when it is normal, you can give fluorescein or IV mannitol to a patient. In other way around, oral steroids can cause increase in blood sugar and blood pressure in few patients. So you have to look at the blood pressure and blood sugar, and only when it is under control, you can start oral steroids for few of the patients. In similar way, ATT is anti-tubercular therapy. Most of them get metabolized in your hepatic system, like liver. So you evaluate and see how your hepatic system is. If your SGOT, SGPT is normal, then you can go ahead and start the patient on anti-tubercular therapy. So before starting the patients on systemic medications, you have to evaluate, look at the pharmacokinetics, dynamics, and then you have to start after ruling out all the contraindications. So as we spoke about the systemic medications, we will now look at few systemic drugs. I think Dr. Ajit has already spoken about the topical medications. We'll look at very few systemic drugs, which is very commonly used in our OPD these days. So oral antibiotic, for example, it's a case of Hardiolam. So here we'll be starting a patient which is commonly ciprofloxacin and common oral antibiotic. It may be given as a BD dosage for 5 to 7 days along with an analgesic, which is a painkiller. So in few cases, it will act as an anti-inflammatory also. So we will be adding an analgesic and for an anti-inflammatory effect. I think you would have heard of antioxidants, which is commonly used for diseases like age-related macular degeneration. So Sir spoke about wet ARMD, where we were giving anti-VEGF injections. Here we are speaking about a dry ARMD, where antioxidants is given as a routine medications. Again, oral medications can be given for diseases related to thyroid related, like neostigmine, where it is given to treat the hypo or hyper status of the patient. Coming to few of other medications, I think Sister Ajita, the pharmacist, spoke to you about what is high risk medications. So in another words, high risk medications are drugs which even in very low dose can cause severe harm to the patient unless given without a reason. For example, in patients with systemic inflammation like rheumatoid arthritis or SLE, few of them may develop inflammatory picture in the eye. We call it uveitis, inflammation of the uveal tract. So these patients will need oral medications to control the systemic inflammation, so that the ocular inflammation will come into control. So that to control the uveitis, we are treating the systemic issues. So for that, we use steroids, and the next step is immunosuppressives like methotrexate. So when we go for such high risk medications, we have to evaluate these patients in detail. Again, high risk drugs it can be dispensed only by a pharmacist. It cannot be dispensed by every other patient. Similarly, it can be written, such a prescription can be given only by a medical consultant who is approved to give a high risk medication, because you have to evaluate in detail and know the patient status before giving such a high risk medication. Similarly, when you administer high risk medication, it has to be verified by two staff. If you don't have two staff, at least it has to be verified twice before giving a high risk medication. Similarly, when you have multiple medication, I think you'll see such a setup in your GA room. When you have ophthalmic cases, for example, squint cases in children, where you do it under GA. So in those cases, you will be using multiple drugs for a single patient, or in a chemotherapy ward, like in orbit cases, when they have ocular tumors where you are giving chemotherapy, there again you will be giving multiple medications. So if you are going to administer multiple medication, when you are loading the second drug, the first drug should be labeled. So unless you have labeled a drug, that means it has to be discarded. A drug without a label means it should not be used for the patients, because we don't know what is the concentration of the drug, what is the content of the solution in the syringe, or when it is loaded. So the drug which is not labeled cannot be used for a patient. So coming to test dose, we spoke about lot of contraindications and we spoke about lot of adverse drug reactions. So in few cases, we have to give a test dose, that is giving the same drug in a smaller quantity to see whether the patient has any adverse side effects towards the particular drug. So commonly in ophthalmic setup, we do it for fluorescein. So it is usually done in two setups. Like one, we know that the drug may develop allergy, like the patient may have allergy for a drug. For example, in lot of patients, fluorescein may cause allergy. So as a routine for all FFA, we give a fluorescein test dose first, followed by the FFA procedure. Fine. So in other way around, few patients have allergy to lot of drugs. So it's not the drugs problem which is causing the allergy, it's the patient who is prone for that condition. So one, it may be the fault of the drug, or two, it may be the patient's tendency towards developing an allergic reaction. So we keep speaking about fundus fluorescein angiography. I think from the beginning, even Dr. Aji spoke to you about fluorescein. So what is fundus fluorescein angiography? It is an invasive procedure which is done to evaluate the retinal vessels or the retina and the choroid. Usually it is done in patients with diabetic retinopathy to differentiate whether they have NPDR or PDR. And also in me being a UVA consultant, I am interested in showing a lot of UVA pictures. So this is a patient with uveitis, patient with retinochoroiditis. So in those cases, we do fundus fluorescein angiography to see how much of inflammation is there in the retina. So in these cases, some patients may develop an allergy to fluorescein. So you have to document that this patient is allergic to fluorescein. You cannot inject the fluorescein dye again. Then we have something called drug recall. So only when you have documents and if you realize that for a particular batch, lot of patients are developing reaction, then you can go ahead and recall that particular batch from the system. Maybe the same batch has gone to a lot of hospitals, then you can recall all those medicines with the particular batch name and the number. So again, we were speaking about systemic medications. So when you are going to administer, either it is systemic medication or a topical medication, you have to have a basic knowledge. I'm giving an example as mannitol. So you have to have a basic knowledge like this example about all those drugs before you decide to put that inside the patient's eye or mouth or intravenous or IM injection. So for example, if I am using mannitol, I should know what is mannitol. Mannitol is nothing but a simple sugar which does not get absorbed much into the system and gets excreted through the renal system. So I should know what is that particular drug. Why am I using the drug for the patient? So usually mannitol is used to decrease the intraocular pressure. Maybe in the preoperative, it's not as a routine. You don't send every other patient with intraocular pressure or glaucoma with mannitol. So usually this is used preoperatively before going in for a cataract surgery where the IOP is high, or in cases like phacolytic, like where the lens has increased the IOP, like the breakdown of the lens material has increased the IOP in the patient. So this is the use commonly used in ophthalmology. What are the side effects? So as it was stated earlier, the mechanism of action was stated earlier. So they said it pushes the fluid out of the system. Okay, so when it increases the urinary output, and hence the patient can get dehydrated, and there may be a electrolyte disturbance. So these are the side effects, and I think we stated earlier, because it is getting excreted through the renal system, your kidney should be functioning well, your urea creatinine should be normal to start a patient on IV mannitol, and the physician's fitness should be there before giving a patient IV mannitol. Method of administration. So it is a IV drug, but it has to be given as a slow infusion over a period of 30 minutes. And you should know it starts acting, like the full effect comes only after 60 minutes to 1.5 hours. So if you want to operate on a patient, you have to start IV mannitol 2 hours prior to the surgery, so that it will take 30 minutes for you to infuse and 1.5 hours for the drug to act, so that you can comfortably act on the patients. Like, you will get the complete effect of the drug only if you have given done the procedure, started the procedure 2 hours before the surgery. What are the special precautions? As said earlier, the patient's fluid output is high, so the patient is dehydrated, so the chances of systemic instability may be there. So do not make a patient to walk around after giving IV mannitol. Either the patient has to be shifted in a wheelchair, or it's better to keep the patient in a structure and shift it into the OT. So what I am saying is, this is just an example. So when you are giving a systemic medication or a topical medication, you should have a complete knowledge of why you are giving, how are we giving. So if I give IV mannitol 3 hours or 4 hours prior to a surgery, it's not going to work. It's just a side effect added to the patient's system. Okay, so only if we know everything in depth, then we can use it appropriately for the patient. Thank you, and I thank again for giving me such an opportunity. Thank you, sir.